what I was asked to speak about is a really light dusting of the immune players in this disease. I'm not going to go into any depth except for one area that we've been personally involved with, just over 3 slides, just to allow just a broad exposure to the talks that you're going to be getting later today. I do have a disclosure that's relevant to this talk, which is that I'm one of the founders of ICOS, which is a company that currently investigates the role of LTB4 antagonism in clinical PAH, and I'm going to talk a little bit about LTB4 in my talk. So just going through the outline of what I'll discuss today, I'll list the main players, which is not going to be very helpful, but then I'll try and frame the story in terms of pulmonary hypertension as a disease of failure of immune regulation, mostly thinking about regulatory T cells, but as Mark Ormiston will talk about, there are other cells that are involved as well. I will also talk about the immune components that become at play when immune regulation goes away, and this, I think, addresses part of Mark's question. I think I'll drill down more deeply on B cells and macrophages. I'll touch a little bit on sexual dimorphism and immunity in 1 slide, or 2 slides, and then conclude on LTB4 and other future targets. Okay, so this is just a matter of opinion. Who are the main players? I think framing the story of pulmonary hypertension as a failure of immune regulation. I think the regulatory T cells, Th17 imbalance, will be proven to be important in the development of certain types of pulmonary hypertension. Macrophages identified by LTB4 and GM-CSF appear to be important. NK cells, as I'll discuss, or actually as I won't discuss, as Mark will discuss, are important. B cells and their antibodies, we're actually not sure if it is the antibodies that are important or if the B cells are actually more important than the antibodies that evolve from them. There's a laundry list of cytokines which can sometimes demean their importance. So I will talk very briefly about them, but I think that they each have their own important roles that emerge with the lack of immune regulation. We're going to hear a little bit today from Kurt Stenmark about the activated fibroblasts. No one's going to talk today, I think, about activated platelets, but I think that that's going to be an important component of this disease. And I will conclude on estrogen and neutrophils. So Mark was poking fun at me about being the loud voice in the room on immunity. So why have we had to be a loud voice? Well, I think for people that have been involved with the field since the 80s and 90s, the field really evolved out of vascular biology. And while there was an appreciation that inflammation was important and present, it was undeniably important that the vasoconstriction was contributing to this. And so I don't know if it's because the field was dominated by cardiologists and pulmonary vascular biologists, but we really focused on the vasoconstriction component, and many of us were personally impacted on being turned down for editorials and articles because this was seen to be an epiphenomenon of the disease. Part of the reason for that is that immunosuppression doesn't always work in pulmonary hypertension, and if steroids don't reverse the disease, then how could these immune cells be important? And there are a lot of them, and of various flavors, which I'll go into. These are the cytokines that I think are known to be important that we reviewed in this Circ research paper. I'm just going to go out and say I think the ones that are going to prove to be important through work that Mark Humbert started a long time ago and it's being investigated clinically at VCU. IL-1, I think that IL-6 is undoubtedly going to be an important player. And IL-13, as Ruben Tudor may talk about in terms of Th2-dominated diseases, and I think TNF-alpha. These are the ones that I personally think are important. And I believe that the reason why you see this cascade of inflammatory cytokines arise is because there's a growing appreciation that there's a Th2 Treg imbalance. I'm not sure how good the quality is of the data that was produced in this Chinese study, but what they show is at least cursory evidence that there is an imbalance of Th17 and Tregs in connective tissue disease, pulmonary hypertension. As I'll discuss, there's a variety of quality of papers talking about regulatory T cells that are detected in the periphery. Most studies tend to indicate if you use CD4 and CD25 and FOXP3, that there's actually an increased number of abnormal T cells, Tregs in the peripheral blood, and perhaps decreased Tregs in the blood. This is a study that was just published in a journal called Heart Vessels that shows that you actually have an increased number of non-suppressive Tregs that you see in a higher quantity in pulmonary hypertension. Mark Umber's group has published on this adipokine, so a cytokine that's released from fat cells, that these levels of leptin are higher in patients with pulmonary hypertension, and the receptors for leptin on Tregs are higher as well, and they have abnormal suppressive function. So this is a really interesting story that his group has developed. And then I'll also mention that Ralph Schmerli's group showed that while you may have increased abnormal Tregs in the blood, you have decreased Tregs relative to control lung in the lungs. And again, I can't attest to the quality of some of these studies, but they're very intriguing and they seem to be going in one direction. And I'm just going to shout out to Marlene's talk at 2:20 today, where she's going to talk about some interesting new data showing abnormal Tregs with Cytof in her PAH patients. In terms of the NK cells, I wanted to plug Mark's talk coming up later today, and he's going to talk about how NKs have a very interesting normal regulatory function in pulmonary hypertension, which may be missing. All right, so just in terms of framing the whole inflammatory way in one package that's easy to understand, when there's a vascular injury, and we think, as Kurt will talk about, we think that a lot of the inflammatory cells park in the adventitia when there's which is largely fibroblasts which become activated. They can injure the intimal cells and the smooth muscle cells. In the setting of normal immune regulation, which you don't always have in connective tissue disease, in fact, most often you don't, but when you have normal reparative immunity with normal levels of IL-10 and macrophages, which are anti-inflammatory, you can resolve this to health. In the absence of immune regulation, which has a variety of flavors, it can be very different in different disease states, you do not resolve this, and pulmonary hypertension may emerge. This is one way of thinking about why inflammation contributes to the disease. Thinking about it simply, this could be divided into two types of immunity, Th1, Th17, that has a cascade of cytokines that are associated with most notably IL-1, IL-6, and then IL-17. You see all the harbingers of an autoimmune response, including mast cells. I'll just quickly say on the Th2 side, which may be important for the most common form of pulmonary hypertension in the world, which is schistosomiasis PH, it calls for maybe a different way of understanding how impaired immune regulation contributes to the disease. And so I just want to highlight that Ruben is going to be talking about that aspect of Th2, and hopefully I think Kurt may touch on the adventitial contribution. Rasa Timosian in our lab basically discovered how immune Tregs, the fact that they're missing in athymic animals is the reason why athymic animals are so predisposed to developing pulmonary hypertension. When she restores Tregs into inbred, MHC identical rats, she prevents the proclivity of these animals developing PH. You see an interesting influx of Tregs into the lung and upregulation of BMPR2 cells around the lung and restoration. When you don't restore this activity or you impede it by blocking PD-1 or blocking heme oxygenase 1, or you get this massive influx of inflammatory cells. And we see this is a phenomenon that's observed across 3 genetic backgrounds of rats. So I think it's a generalizable phenomenon. Quickly, I'll just say one of the most prominent things we see in immune dysregulated pH is a lot of B cells. And I want to take this opportunity to welcome the NIH here today, CBEV, and our ASCO1 investigators. So the first immunotherapy trial, which was actually funded, I think, in 2006, started in 2010 after 3 or 4 years of planning, and is just coming to an end now. It should conclude in mid-2016. So this is the first multi-center trial for immunotherapy in pH. So far, we have 44 out of 60. It hasn't gone to 45 yet, right? 44. And we have 18 sites in the US. Many of the investigators have come today. This includes mechanistic studies with a 63-plex cytokine analysis. The Quake Lab's doing B-cell clonality, B-cell phenotyping. The Wall Center has funded an MRI study, which Roham Zamanian is leading. And we have some new interesting mechanistic sub-studies looking at the microbiome and virome of systemic sclerosis PAH patients. And we're also doing Treg phenotyping with the Human Immune Monitoring Core. So going quickly through the other cell types that we see, I think one of the most exciting areas, personally, I find exciting is the notion that these macrophages are not mere accessory cells that I cut my teeth on these cells being kind of mop-up cells. But I think what we're starting to see is that they're actually effector cells in autoimmune disease. And we also see increased dendritic cells and definitely increased mast cells in disease in various proportions in different types of PAH. So with all this, we have an increase in effector T cells, and so this whole thing gives you the flavor of an autoimmune disease. And so the notion that the inflammation that we see in pulmonary hypertension is simply an epiphenomenon of a high pressure head, which is what I was told multiple times in the early 2000s, that because we have high pressure in the lungs, that's the reason we have inflammation. I think that reasoning can be called into question. And certainly the female predominance that we see in PAH is matched by the fact that there's female predominance in autoimmune diseases in general, and many of these diseases are associated with pulmonary hypertension. And I'll just say very quickly that Rasa in my lab and looking at the literature out there, it's very interesting to see how estrogen itself might be influencing immunity, and it's extremely complex. The notion, in my opinion, that blocking estrogen or promoting estrogen is going to be helpful, and this is meant to be contentious, is I think very much open for discussion. What we think is happening is that when you have abnormal regulatory T cells, we have some evidence to suggest that the damaging effects of estrogen on immunity outweigh, and that may be the reason why women are predisposed to developing PAH over men. However, in health, the cardiovascular protective effects of estrogen dominate, and when you have normal Treg activity. It's too complex for me to get into now. It's a very complex area, but I think even though it's complex, it's important. Right now, there's a number of preclinical targets that have been shown to be effective. I think a lot of people in the room are excited by Etta and Marlene's work with FK506. It does target the immune response, but the reason why this was chosen in low doses was to upregulate BMPR2 signaling. So a very happy marriage of genetics and anti-inflammatory in terms of its targeting mechanism. We're, as a group, particularly interested in LTB4, but certainly there's other agents here that are being tried in preclinical models that are interesting. What am I doing for time? Okay, I should probably go quickly. Okay, so I've shown this slide a few times. Our interest in LTB4 it does not start with us. People presenting today, Kurt and Norbert carried this work forward, and I'm gonna go very quickly because I don't want to slow us down. This work got carried forward in the 1990s and was brought forward by Joe Lascalzo's group and Zhang's group at Harvard in the early 2000s, and we picked up on the story and found that if you take macrophages out of rat lungs with pH and you co-culture them with endothelial cells, basically you can induce endothelial cell death. And we know now that these cells that don't die, the ones that are left living, proliferate and are transformed and become abnormal. So the macrophages are, and we've basically, without showing you the data, we've been able to pinpoint LTB4 as one of the important mediators liberated by macrophages that cause this change. I'm gonna gloss over this to stay on time. We basically we ringed the whole eicosanoid pathway, and really all the therapies that worked on limiting LTB4 basically reversed advanced pulmonary hypertension in several disease models, and we see evidence of high LTB4 in humans and in their tissues. I'm sorry to go fast, I just want to stay on time. So right now, in terms of clinical trials that are being used to target pulmonary hypertension that focus on immunity, we have, although complete, I think they would acknowledge, Roham and Etta are continuing to work on this very exciting FK506 pathway. As I mentioned, we're concluding the rituximab study soon. I thought that this was a dead study at VCU, but I think it might be going again, targeting IL-1 receptors. And going forward into 2016, Ubenimex targeting LTB4 will get started, and some very exciting work targeting a neutrophil elastase inhibitor that's really being led by Marlene Rabinovich and Roham, that I'm also a part of, will be looking at targeting innate immunity with this. So in summary, personalizing immunotherapy for different PAH phenotypes is a major goal for the next decade. Immunotherapy should be considered as an adjuvant to vasodilators, with likely combinational strategies with other adjuvants being important. And we need to understand protective immunity too, getting back to Mark's question. We actually have a proposal in the future of using Treg infusions as a form of immunotherapy. And I'll stop there. Thank you.
Mark, just to get back to one of the first things that you said in your talk, and I'd like to hear some rationalization between that and what you said towards the end, which is one of the reasons I thought why the whole idea of an important causative role of the immune response in PH was, as you said earlier, the failure in many cases of immunosuppressive therapies to impact the course of the disease.
Right.
So could you just talk a little bit about how we can reconcile that rather crude kind of immune intervention with the idea that this is having an important causative role?
Right. And I think I can remember distinctly having a conversation with Ginny Steen at a PHA meeting, yeah, years ago about this. And it was about when we were just starting the rituximab trial. Two thoughts. One is that probably everybody in this room would agree that inflammation is important at the beginning of a rheumatologic process. I don't think that's controversial. The question is, by the time it's detected, have you moved on to a post-inflammatory state where immunomediated targeting is not important? That's idea one. The second idea is different types of immunity call for different types of specific treatment. So, targeting IL-13 is far different than giving steroids, corticosteroids. I know Ruben wanted to say something.
So what I'd like to say is that to address Mark's point, I think that the fact that the immunosuppressant doesn't work is not an argument. It's just that it highlights the complexity of the issue. And one of the issues that I would like to highlight, what we need to understand better, is that how the immune system all the cells that you highlighted, and I think that the macrophage is pivotal in this system, how it interacts with the blood vessel, and therefore how it is a vascularly specific disease rather than being asthma, rather than being a RA-type interstitial disease, which I think that we don't understand. There is a compartmentalization of the immune response in crosstalk into the blood vessel that doesn't crosstalk as much with the airway, it doesn't crosstalk with the lymphatic system and the alveolar space. And I think that this is what we don't understand. This regional, regional clustering of the cells crosstalk into the blood vessels. And therefore, until we don't understand that part, we cannot understand why certain immunosuppressants work or don't work, usually don't work, because if the compartment is secluded from where the steroids are going to reach or any immunosuppressant, you're not going to have an action. So I think that the data, until, of course, you fulfill all the Cox postulate, you're not going to be satisfied. But there is evidence that's there. The crime has been committed. There is spillover of the, damage, and there is a very close association. How far you go after that depends on how much we can understand of this dynamic, and hopefully we can discuss a little bit more about exactly about this.
It seems to me that one of your early slides was particularly critical when you said everybody would agree, I like to start at least with that, everybody would agree that initially after the injury to the vessels, there is a positive response of the immune response in facilitating restoration and repair of the injury. And then in some cases, maybe especially in the setting of autoimmune and other dysfunction, you get into a situation where it is antagonistic because there's not resolution of the injury. And so one of my questions to you and the other immunologists here is, who are the first immune cells that are on the scene during that healthy reparative phase? And so could you just tell us who are the first responders and are thought to play a role? Is it the macrophages? Who's there first and facilitating the healthy repair?
Yeah. So I don't know if it's the same for every autoimmune process.
I'm talking about not the autoimmune. I'm talking about in the normal resolution of the injury, where you talked about the role of immune cells in the healthy repair.
Right.
Who are the immune cells that are there first responding and involved in the healthy repair?
I don't know. It's either the main ones are regulatory T cells, and they're possibly NK cells and anti-inflammatory macrophages. But I'm actually, Marlene, see. What's that? Yeah. Neutrophils.
Yeah.
But are you talking? But Mark, so neutrophils in the terms of mopping up, as opposed to dampening inflammation. That's.
All I want to know is who's.
Can I? He wants to know who's first, right? I mean, but I think that's a very difficult question because there are different kinds of injuries that elicit different responses. So if I can speak to only one kind of injury that we study, and one could argue that it's not really an injury, that's hypoxia. So we've studied pretty carefully starting at 12 hours, and at every time point thereafter, sort of the influx of cells. Within the first 12 hours, you see neutrophils and macrophages. And then the neutrophils, for some reason, in the hypoxic models, the mice, the rats, the calves, so 3 different species, that's the case. Then, and it's very clear. I mean, we did time course analysis. Jack Reeve sat under the microscope, because I couldn't, stand that. And counted every cell for every day, all the way out. And macrophages. Now, that's not true in every disease process, right? And what, I don't have time to mention it today, but what we're extremely interested in the most robust model that we have, the CAF model, you continue to accumulate macrophages. They're specifically polarized into a very distinct state, at least for the first few weeks of the disease. I think that changes thereafter. But there's a microenvironment that's been created that's almost the same, not the same, but as in cancer, that the immune response then becomes dysfunctional. For whatever reasons, we've tried to work, we have some pretty good immunologists, even though Mark left, in Denver, that are interested in T cells, and there are no T regulatory cells, just as been described in the human. And so your question is a difficult one. If we look again, though, at a similar thing in the systemic circulation, so working with Mary Weiser-Evans, we do a balloon injury to the carotid artery. And I did it for specific reasons because I always wanted to know where they were. But as Mark Nicolls points out, that they accumulate within hours on the outside of the blood vessel wall, even though you do the balloon injury from the luminal side. And they're macrophages and neutrophils. Later you do get T cells, but it takes a long time in our hands and our models to get T cells and the B cells. Ultimately, they're there, but fewer in number, as was pointed out in the Savai study.
You think that those are resident?
Well, we've worked really hard to figure that out. So yes, I think there is a strong possibility that the first responder is the resident, and it's a very distinct macrophage in the vessel wall. That we have a paper, hopefully, will soon be published. Who knows? That those cells are very different than the alveolar macrophage. They have different responses to the similar stimuli, and so yes, I think that's really important. But labeling studies, because the mouse doesn't allow us to study sort of the human condition, or like the bovine cells, it's been difficult. But we talked about this several years ago in your lab. I think that the resident macrophage could, expand, and at least the labeling studies that we've done would suggest that yes, it does. And so the resident cell, I think, initiates, it expands. It recruits new macrophages, but the new macrophages in our hands don't exhibit the exact same phenotype that the activated resident macrophages do.
To the immunologist, there are about 80 types of autoimmune diseases, and only a few really are associated with pulmonary hypertension. Can we distinguish the different autoimmune diseases, which different cells are important there? And then another question, do generally autoimmune diseases respond to immunotherapy to like steroids? And if yes, then I think we can't really say, that PH is really an autoimmune disease. So can anyone comment?
Okay, so one of the arguments that I had early on in this is that it's interesting that for other types of organs that are affected in connective tissue disease, there's not much argument that the vascular injury that you're seeing is attributable to the connective tissue disease that is in the body, throughout the body, that's systemic. Why would that be? I mean, why are you saying that you accept that autoimmune contribution is important in connective tissue disease, but maybe not in idiopathic? Is that what you're saying? Okay.
So maybe